Good morning, and I would want to both welcome myself as well as welcome everybody in the audience. And I'd like to observe some necessary protocols to acknowledge the presence of the special guest of honor, who is the Honorable Commissioner of Education, Anambra State, in the person of Professor Ngozi Chuma Ude, and followed by the Acting Vice Chancellor, Sir Professor Kate Azuka Omenua. As they say that there is a time a woman becomes Nemo. It is indeed my pleasure to also acknowledge the presence of the chairman of the occasion, KSQ, KSJIJP, Ichie Obama Nobi, Etu Dike Aguleri, in the person of Lord Dr. Mike C.O. Omenua. I have the indefatigable host who has been with me for the past 1 year, literally, on this speaking engagement, in the person of Professor Nkiruka Mary Kate Oji, the host faculty of Health Sciences and Technology of Chukwuemeka Odumegwu Ojukwu University. Also the chairman of the LOC, Dr. Obi Onyema Ilo, and other guest speakers, Professor Tobias I.N.S. Ejiofor and Professor Clementina Yu Wankwo. Distinguished audience and all staff of the highly acknowledged Faculty of Health Sciences and Technology, Chukwuemeka Odumegwu Ojukwu University. At this maiden International Health Science, Technology, Innovation and Entrepreneurship Conference and Exhibition, which is both live and virtual, with the theme Artificial Intelligence, its application and implications in medical practice. I would like to start my presentation with a quick definition of AI. That since the technology is common knowledge now, there is no need to labor over the definition. However, John McCarthy described the term artificial intelligence, AI, as the science and engineering of making intelligent machines. Artificial intelligence was initially introduced in 1950, before I was born. So many things that never happened before I was born. So this is quite instructive. But early models faced numerous limitations that hindered their broad acceptance and use in medicine. By the early 2000s, many of these limitations were addressed with the emergence of what is known as deep learning, DL. With AI systems currently able to analyze complex algorithms and learn independently, we have indeed entered a new era in medicine. AI can now be integrated into clinical practice, enhancing risk assessment models, diagnostic accuracy, and workflow efficiency. So we need to just look critically at how artificial intelligence is being used in medicine. Some of the applications of artificial intelligence in medical practice. Artificial intelligence in medicine is the use of machine learning models to help process medical data and give medical professionals important insights that will enable them improve health outcomes and patient experiences. And this is very critical. In healthcare, we know that the patient is the number one focus. And anything that is able to improve health outcomes and patient experiences is a winner already. There are numerous ways that AI can positively impact the practice of medicine, whether it's through speeding up the pace of research or helping clinicians make better decisions. Thanks to the recent advances in computer science, I'm sure there are so many computer scientists here and informatics students and faculty, artificial intelligence is quickly becoming an integral part of modern healthcare and our modern world. AI algorithms and other applications powered by AI are being used to support medical professionals in clinical settings and in ongoing research. Currently, the most common roles for AI in medical imaging in medical settings are clinical decision support, that is, systems that have been put in place to support clinical decision, and imaging analysis. Clinical decision support tools help the healthcare providers make decisions about treatments, medications, mental health, and other patient needs by providing them with quick access to information or research that's relevant to their patient population. The challenges that the COVID-19 pandemic created for many health systems also was contributory in leading many healthcare organizations around the world to start field testing new AI-supported technologies, such as algorithms designed to help monitor patients and AI-powered tools to screen COVID-19 patients. The research and results of these myriad of tests are still being gathered, even though AI has made profound inroads and left profound footsteps in the science of medical science. And the overall standards for the use of AI in medicine are still being defined till date. Yet, opportunities for AI to benefit clinicians, researchers, and the patients they serve are steadily increasing and steadily being accepted by all with relief, instead of the fear that encompassed everybody that AI has come to take our jobs. In fact, some of us who I'm sure are high-level Christians know that one of our greatest prayer requests is always destiny helpers and burden bearers. Now we have AI as destiny helper and burden bearer. So at this point, there is little doubt that AI will become or has become a core part of the digital health systems that shape and support modern medicine. In terms of AI in disease detection and diagnosis, unlike humans, AI never needs to sleep. Machine learning models could be used to observe the vital signs of the patients. I'm sure you've had harrowing experiences of being a caregiver for one family member or the other, and the healthcare providers are sleeping whilst the drip has run out, or the machine, life support machine is running amok and nobody is waking up. I know that I've had my child wake up in a pool of blood who was on drip because the drip came off. So AI is being used to observe the vital signs of patients receiving critical care and to alert clinicians if certain risk factors increase in the patient they are managing. Whilst medical devices like heart monitors can track vital signs, AI can collect the data from those devices and look for more complex conditions such as sepsis. One IBM client has indeed developed a predictive AI model for premature babies that is 75% accurate in detecting severe sepsis, which is one of the critical situations in that category of patients. Now we come to the almighty radiology and imaging, AI in radiology and imaging. Artificial intelligence applications are increasingly being created and deployed worldwide in every sector. Radiology, which is my area of discipline, has experienced the most profound utilization of AI, honestly. In medical imaging, AI tools are being used to analyze CT scans, X-rays, MRIs, mammograms, and other images for lesions or other findings that a human radiologist might miss. Indeed, radiologists are often chastised because they will say it could be in their final diagnosis, but they're not pathologists anyway. They're supposed to use the images they have, studied to extrapolate what the patient could have, but they can give you the exact site, the dimension, and that will guide you if you're going in for surgery. However, they are often very misunderstood to be pathologists. All our diagnosis is actually more or less extrapolated. So the use of AI in medical imaging has found relevance in enhancing accuracy, imbuing consistency, and conferring reporting efficiency. The latter, reporting efficiency, reminds me of the emergence of computer-aided detection, CAD, in radiology, which dates back to the early 2000s. Mostly popular at that time for sorting out abnormal mammograms. Mammogram is the imaging that we use soft tissue radiography to be able to acquire images of the breast that will enable us to detect breast diseases or abnormalities. And I am assuming now that it was one of the earliest attempts at AI in medical imaging in medicine. Significant advancements and increased adoption has taken place over the past 2 decades, with the following notable milestones and studies related to computer-aided detection in radiology. So running through 2004 to 2023, we have 2005, 2007, in 2004, CAD was considered for adoption in other countries besides the USA. 2005, Castellino and others presented CAD as virtual second reader, which is how we met it. It's a second reader, the one that will identify and sort out mass screening of mammography and sort out the ones that are likely to be abnormal, and then the human radiologist will now go through those ones that have been sorted out by the computer-aided detection. So in 2007, Kuna et al. Demonstrated the existence of a low prevalence effect in visual search tasks. Gilbert et al. In 2008 conducted a study on CAD benefits and so on and so forth, and we ran through 2010, 2013, 2015, 2017, 2021, 2022. Because of time, I'll not go through all the different milestones, but significantly, in 2021, Kuna et al. Published research on the low prevalence effect and computer-aided detection. I'm sure some of us must be asking, what is low prevalence effect and what does it stand for? The low prevalence effect refers to the low prevalence effect in visual search tasks, as is searching visually for abnormality, particularly in the context of medical imaging and computer-aided detection. It describes the phenomenon where radiologists and clinicians are less accurate when searching for rare or infrequent abnormalities, such as tumors or fractures on images, just as I described earlier. So this effect has important implications for the design and implementation of computer-aided detection systems in the healthcare, highlighting the need for careful consideration of how these systems present information to clinicians to maximize diagnostic accuracy. You can imagine, at that level of computer-aided detection, we are talking about so much accuracy. You can imagine what we're achieving now with AI systems. By 2017, AI started making inroads into other areas of medicine. Arteries became the first clinical cloud-based deep learning application in healthcare that was approved by the US Food and Drugs Administration and provided to doctors to diagnose heart problems. Most of these organs are hidden from the naked eye. So you have to interrogate them by using images that can go through them. And we're contending with what you call two-dimensional imaging, where we did all manner of, gymnastic extrapolations to be able to know which tissue we are seeing that is behind the heart, in front of the heart, at the middle of the heart, at the back of the heart, at the level of the spine. So this provided to doctors to diagnose heart problems and other conditions. And the Arteries AI platform has also received CE mark for commercialization in Europe. Deep learning can be utilized to detect lesions, generate differential diagnosis, and create automated medical reports. Such a pleasure. In 2017, Gajeye and Leng used deep learning to screen for diabetic retinopathy. I mean, you need to pity the ophthalmologists when they are screening, going through using all sorts of gadgets to see and diagnose diabetic retinopathy. And here presto, this deep learning technology has been able to achieve 94% sensitivity and 98% specificity with 5-fold cross-validation, which is a technique used in machine learning to evaluate how well a model can generalize to new unseen data. Similarly, Estavia et al. Trained a convolutional neural network, another hidden organ, the brain. You can imagine that we need to do craniotomies, actually open the skull cap to be able to have the imaging access the brain, or to introduce all sorts of contrast media, which may be, which are sometimes quite toxic to the body, in order to outline the vessels. And then with how the vessels are displaced, you are now trying to interrogate and see what is happening. Is there a tumor? Is there a mass lesion? Is there a displacement? And all that kind of thing. So it showed that this convolutional neural network's performance was comparable to that of experts. They also utilized this to achieve early detection in dermatological lesions, such as differentiating keratinocytes, carcinomas, which are malignant, from seborrheic keratosis, which are benign, and melanomas, which are malignant, from nevi, which are benign, representing first the most common skin cancer, and the most common deadly skin cancer. Now, they used 45,000 images in training this model. Right now, we are involved in a study with our collaborators in Stanford that is using 500,000 images in training the model for skin lesion. Such models are open to collaboration to include images from African countries with a significant burden of skin cancers, especially in our albino population. And I'm sure that your university will be interested, or maybe you will be interested in being included as part of collaborator. Right now, we are working with images from UNTH and from Luth, which we have contributed to a Stanford ongoing training model. Due to this study, Stanford University invited me to Stanford last month, so we can explore further collaborations, and we roped in their collaborating institution, University of Pennsylvania in Philadelphia, to also meet with me and develop radiology-specific AI studies. Thus far, the study that we had embarked on skin images has successfully trained AI over 700 images from Nigeria on the larger Stanford cohort, which has 100,000 images. So you see, we are still lagging behind, but at least our data set population of images are being included, otherwise we'll be excluded. And they are being cross-validated with the algorithm on Stanford images. Images from Nigeria and other non-US images from collaborators in other continents are being included. So the key takeaways we have so far in this study are as follows: that we have consistent performance across all test cohorts. We have good performance in our Nigerian data set, as well as good performance in cohorts the AI has not yet trained on. Now let's look at the big issue of precision medicine, which is, where our hunger is, because it's going to really help us to understand truly that one cap does not fit all. The same treatment that cures patient A does not cure patient B. And this is where the world is going. Precision medicine. So, precision healthcare is an evolving new approach to healthcare poised to revolutionize the health service through technology-driven digital information. So it focuses on providing customized treatment, customized for you, made for you, hallelujah, to individuals, not just for their symptoms. It's like having a personalized blueprint for your health. Scientists are projecting that new clinics will be this one I found really dapper. So where you arrive with your DNA platter as a patient to the clinic, and a customized care is literally rolled out to you. While we are not there yet, quite there yet, precision medicine is moving in that direction. The current realistic scenario runs as such. Step 1, the patient undergoes genetic testing, which we have been doing on some of our cohorts of patients with Covenant University, which involves providing a sample of their DNA, usually from blood, saliva, or a cheek swab. Step 2, the patient's DNA data is analyzed using AI-powered tools to identify genetic variations associated with specific health risks or conditions. For instance, those women that we did mammograms on, we took their blood and sent to Covenant University to pass them through a risk factor assessment for breast cancer. And right now, that cohort is being analyzed, and we're going to keep adding to that data set. Step 3, the patient's genetic data is combined with their medical history, lifestyle, and other factors to create a personalized health profile. By this time, you are literally able to use even imaging to produce the genomic makeup of the patient. So we now have what we call image genomics. So step 4, the patient's healthcare provider uses this profile that he has obtained to develop a tailored treatment plan, customized care, including targeted therapies, lifestyle modifications that the particular patient needs, and preventive measures. You know, this one, don't eat that, don't eat that. These ones are customized for you. Step 5, the patient's health data is then continuously tracked and updated, refining their profile and guiding adjustments to their care plan as needed. So to achieve this proficiency, the AI analyzes genomic data, medical records, and real-time health data. AI looks at the genomic data, which is the information stored in one's DNA like a blueprint for the body, to understand how our body works and what might go wrong with it. So the risk factor, the genetic risk factor, you don't have breast cancer yet, but it's assessing you to see if you have a potential to sometime in the near future or later future have breast cancer. So AI looks at your medical records, medical history, including past illnesses, allergies, medications, which is the importance of ensuring all hospital facilities have a functional electronic medical record, EMR. Please, if you are yet yet to have that, please to put in place this structure. It is so important, and it will improve your access to collaborators and partnerships. And I would like to offer that we have partners who can assist you to be able to digitalize your data and to make it retrievable and usable. So the AI collects real-time health data from wearables, from sensors and other devices to understand your current health state. Machine learning, which is a type of AI that can learn from data like a super smart computer. Algorithms then identify the patterns and predict patient outcomes. Let me tell you, prediction of patient outcome is so vital, it's so key. And it's so important for the patient to understand his journey. So by patterns, we imply that AI looks for connections between the patient's data and the health outcomes, like people with this gene are more likely to get this disease. That's the kind of inference. So we are looking at using even imaging to be able to determine the genomic makeup of the patient. And by predictions, we imply that AI uses these patterns to forecast what might happen if a patient is to have a certain treatment or lifestyle change. So there are goals that precision medicine aims to achieve for us in the healthcare industry. It's targeted to improve treatment efficacy by finding the best treatment for each patient so they get better faster. It's targeted to reduce side effects and avoid treatments that might harm someone based on their unique characteristics. It's targeted to enhance patient outcomes and help people live healthier and happy lives. It's targeted to streamline healthcare processes and enable healthcare to be more efficient so that doctors can focus on what matters most. I tell you, protocoling of every kind of procedure and treatment management that we give to our patients is very important, and EMR will help you to be able to get organized. So while we are making progress, there are still many ethical, regulatory, and technological considerations to address before we can fully realize the promise of precision medicine. But the future of personalized healthcare is exciting and promising. The development of personalized medicine and the imperative of developing it, that is treatment planning based on data specific to an individual patient, has been a challenge in the medical community for decades. Currently, treatment decisions rely on best practice guidelines and a physician's interpretation of the available data. So there is no uniformity in treatment across board, across the nation. With ever increasing clinical volumes and data sources and Jabbar syndrome, this has become a difficult endeavor and results in a generalized treatment approach instead of personalized care. So the patient goes to see a doctor and comes out feeling, I didn't see anybody. I might as well have gone to interact with a machine. So as summarized by the United States National Academy of Medicine, the accumulation of data has created a situation where healthcare providers are responsible for interpreting, aggregating, and synthesizing the data. This is one human brain for beyond, far beyond human capacity. This issue is further exacerbated in low and middle income countries where patient-to-doctor ratios far exceed levels as recommended by the World Health Organization. For instance, a study to assess healthcare facilities and personnel distribution in Lagos State showed a ratio of one general medical doctor to 5,014 people. 5,014 people, one doctor. In contradistinction to the WHO recommended doctor-to-patient ratio of one doctor to 600 patients. This medical manpower deficit has resulted in disastrous implications for the Nigerian healthcare system, such that we have a situation of overwhelmed physicians, leading to burnout, inaccurate diagnosis with inadequate mental bandwidth to process large amounts of data, patterns, dissatisfaction, not implementing best practices as in patient-doctor relationship, stress-induced loss of life, heavy negative impact on patient safety, physician safety, and healthcare system performance. 3 days ago, one very young lady died in Ebonyi State in pregnancy. She was already in labor. She came to the hospital and she died in the hospital before an intervention was instituted. So what is going on? Everybody is doing the blame game on the healthcare provider without understanding the inundating circumstances that they are trying to contend with and cope with. So a particular application in engineering translated to medicine has been proposed as a potential solution to this quagmire of underserved communities. And this is called the medical digital twin. It's another AI solution in medicine. So medical digital twins are gaining popularity both in the scientific community and general public, yet much of the recent enthusiasm lacks a consensus on their fundamental makeup. And therefore, we decided, the Stanford group and us, to interrogate it. Digital twins themselves originate within engineering, where a constantly updating virtual copy enables analysis, simulation, and prediction of a real-world object or process. Digital twins was my first encounter with participation in AI research and publication. So a team of authors in Stanford and myself first decided to translate this engineering concept to medicine. In our ongoing research, we outlined 5 key components of the medical digital twin. And these 5 key components are the patient, the data connection, patient in silico, interface, and twin synchronization. Leveraging these 5 key components, we considered how the various enabling technologies we are trying to twin in multiple modal data, artificial intelligence, and mechanistic modeling will pave the way to a clinical adoption. We provided examples on how this will play out for oncology and diabetes, two very key healthcare tragedies that we are contending with. We also highlighted the role that the data fusion will play vis-a-vis the potential of merging artificial intelligence and mechanistic modeling to address the limitations that each of them individually, if utilized on their own or independently. Of particular interest to us in low and middle income countries is how this digital twin concept can support performance of large language models applied in medicine and its potential in addressing healthcare disparities. Now, healthcare disparities, this is our forte. This is where we lie. There's a huge healthcare disparity in infrastructure, everything. When I visited Stanford and then I visited UPenn, I said to them, if you put me even at this age of 70 in this UPenn, I'll tell you people I work for 24 hours. And I will not ask for any leave or transfer. I will just work. Because how can you be in an environment where everything is working seamlessly, everything is made to be beautiful, everything is made to be accessible, and you're saying you're tired of working? If I was Nigerian, they told me and said, I do extra duties because some of them I do from my home. So we envision that this work will help guide scientists and clinicians to create medical digital twins in the future and translate this promising new paradigm from theory into clinical practice. Now, for my trip to Stanford and Pennsylvania medicine to strengthen collaboration, I thought I should bring it out because I really want to carry Odumegwu University. I'm sure you have other collaborations, but this one is key for this topic we are talking about. So both radiology departments of Stanford and Penn Medicine that I visited between the 24th and 28th of June are significantly at the forefront of innovation. In fact, Stanford, you know, they are the ones that created the Google, what's his name, that is always giving money to low and middle income countries, Bill Gates and the rest of them. It was an eye-opener for me. And my findings resonate so well with what I want to devote the next 10 years of my life doing, God willing. Expanding clinical trials in the African region and exploring and implementing innovative strategies to impact cancer control in underserved regions. And I see that AI has a significant role to play. Even the president of the Radiological Society of North America, where when you go to that Congress, you have over 60,000 participants. I met him in Stanford, and he has so specialized in AI with all his degrees and fellowship that he has. So he has QAPA in AI. Let me tell you, let the train not leave you. I met up with researchers in radiology and computation medicine who are working on the following key research areas and advancements in radiology. It gives us an ability to have an array of the different areas where AI has touched in medical science. So artificial intelligence and machine learning, developing AI and machine learning algorithms to improve image analysis, diagnosis, and treatment planning. And we have the ones that are looking at the subtypes of breast cancer, you know, and the BRCA1, BRCA2. I mean, it was really profound. Number 2, imaging biomarkers. Imaging biomarkers have, you know, identifying imaging features to predict disease progression and treatment response. In fact, quite recently, I became involved with some Netherlands researchers who have delved into, with the medical lab science, have developed a software that is able to early detect 11 different kinds of cancers, with all the common types like prostate, breast, cervical, colon cancer, all included. What more can we be asking for? In one little test with a software, you are able to early detect 11 types of cancers. So, and it's called OncoSeq. It's a story for another day. So, number 3, radiomics, extracting quantitative features from medical images to predict patient outcomes. Number 4, precision medicine, which we've already talked about, cancer research, improving cancer diagnosis, treatment, and monitoring with advanced imaging techniques. We have a number of different groups in America, in England, that we're collaborating with for cancer research. Number 6, neuroimaging, advancing understanding of brain structure and functioning in neurologic and psychiatric disorders. Number 7, cardiovascular imaging, developing new techniques for cardiovascular disease diagnosis and treatment plan. You can see that it was one of the early beneficiaries. Molecular imaging, visualizing biological processes at the molecular level to understand disease mechanisms. Can I just go back to cardiovascular imaging and tell us something? For sickle cell disease, you can actually predict that this child might be nurturing a stroke that will happen soon just by using Doppler imaging. And we are UNTH, Ebonyi State, and all that. We are all involved with multiplicities of institutions are involved in this access of trying to assess sickle cell patients critically and at least enable them to live worthy lives. So number 9, image-guided interventions, using imaging to guide minimally invasive procedures for diagnosis and treatment so that you don't need to be caught up and all that. So radiation dose reduction, at least for image-guided, we're already doing image-guided biopsies of lesions in the breast, and we can do aspirations from the liver, from the spleen, from the abdomen and all that. And so we assist to guide even from the kidney and all that. So number 10, radiation dose reduction. So with all these accessibilities that is created in the imaging domain, techniques have been developed to minimize radiation exposure while maintaining image quality. So Odumegwu Ojukwu University can join this collaboration. These research areas are constantly evolving, and our dialogue has opened new vistas of opportunities for Africa to be significantly involved in these research pursuits and not to be left behind or lag behind as we did some in the early 80s and 90s, when me, as a radiologist in the 90s, I could not interpret a journal, a foreign journal. I couldn't read it and understand it because it had all the, cross-sectional imaging, articles, and we didn't have any cross-sectional imaging. We didn't have ultrasound. We didn't have, we did have ultrasound by 1990, but in the 80s, early 80s when I joined the residency, we didn't have. So mammography, we had in 2007, the first time we had mammography. CT scan, the same thing in 2000, and it was a 2 slides when others were already dealing with the 300 and something slides, 600 and something slides, 64 slides and all that. So we experienced extreme deprivation in availability of cross-sectional imaging, and therefore we had a death. A lot of our residents were trained to become radiologists without ever having contact with a fluoroscopy machine. We are determined, I tell you, to be running on par with technology and research innovations, especially in AI-driven radiology research. There is a facility, a structure, an organization called RAD8 that is headed by a Nigerian, and he is also domiciled at UPenn, and I met him and we went into discussion. They've already done some cohorts in some African countries and in Nigeria to show that utilizing AI will assist us to deal with our manpower deprivation. So scarce or absent radiology resources impede adoption of artificial intelligence. for medical imaging by resource-poor health institutions. They face limitations in local equipment, personnel expertise, infrastructure, data rights frameworks, and public policies. The trustworthiness of AI for medical decision-making in global health and low-resource settings is hampered by insufficient data, diversity, non-transparent AI algorithms, and resource-poor health institutions. Limited participation in AI production and validation. This is the current focus of my intervention, to introduce into the global data set images from our African sub-region to close the gap in non-participation in AI production and validation. RAD-8's three-pronged integrated strategy for AI adoption in resource-poor health institutions is presented in two articles, which includes clinical radiology education, what they did in clinical radiology education, infrastructure implementation, and phased AI introduction. This strategy derives from RAD-8's more than a decade experience as a non-profit organization developing radiology in resource-poor health institutions, both in the United States and in low and middle-income countries. The three components synergistically provide the foundation to address healthcare disparities. Local radiology personnel expertise is augmented through comprehensive education. Software, hardware, and radiologic and networking infrastructure enables radiology workflows incorporating AI. These educational and infrastructure developments occur while RAD-8 delivers phased introduction, testing, and scaling of AI via global health collaborations. Odumegwu Ojukwu University can be part of that global health collaboration. Take-home points. AI solutions can be successfully installed and used in various low and middle income settings by using a strategy that focuses on education, infrastructure implementation, and phased introduction, requiring a commitment to long-term engagement and partnership. This is needed to overcome AI adoption barriers in low and middle income countries related to limitations in personnel infrastructure, IT support, and policies. AI offers a potential solution to global health inequities by improving access to health services in low and middle income countries through healthcare performance optimization and cost reduction. The adoption of AI in low and middle income countries requires tailored strategies to overcome unique limitations in personnel infrastructure, IT support, and can you use your, listen, I need to know, I can't see the light, please. Okay. So, concluding now, RAD-8 International has provided guidance for equitable implementation of AI in low and income countries with a three-pronged approach of clinical education, infrastructure implementation, and phased AI introduction. The advancements in radiology research are truly remarkable and not to be looked down on and not to be ignored, and hold great promise for improving patient care and outcomes. The integration of artificial intelligence, machine learning, and other cutting-edge technologies is transforming the field of radiology and enabling healthcare professionals to provide more accurate and personalized diagnoses and treatments. It's an exciting time for radiology, and I'm glad plus highly enthused about it, and definitely putting my hands on this plow and calling Odumegwu Ojukwu University to put their hands on the plow. In conclusion, AI in medical practice is relatively new development that is revolutionizing healthcare in several ways, including, please put, oh wow, a light. Everybody knows our infrastructural deficiency now. So, clinical decision support. AI algorithms can analyze patient data and medical research to suggest treatment options. Medical imaging. AI algorithms can analyze medical images to detect signs of diseases such as cancer. Personalized treatment plans. AI can analyze patient data to create customized treatment plans. Administrative tasks. AI can automate tasks such as data entry and appointment scheduling. Drug discovery. AI can analyze data to find new drug combinations and designs for the patient. Then patient care. AI can help with patient care by analyzing the vital signs. It doesn't sleep, it doesn't slumber, but he's not God, and providing real-time feedback. Connect with us. Emeritus Professor Ifeoma Okoye, Director, University of Nigeria, Center of Excellence for Clinical Trials, ONSEC, or through the UNN website homepage, University of Nigeria Nsukka, Research Groups, University of Nigeria Nsukka. Thank you very much.